we also show data from the JAVELIN Bladder 100 trial, and I think that's important to also highlight. This trial, as we know, presented data about 4 years ago with switch maintenance avelumab plus best supportive care versus best supportive care alone in patients who had response or stable disease to platinum-based chemo. So GEM-CIS or GEM-CARBO, patient had response or stable disease, and then they went on to avelumab switch maintenance, and there was an interval between 4 and 10 weeks between the end of chemotherapy and start of avelumab maintenance therapy in that trial. Primary endpoint was overall survival. That was met, and there was a significant improvement in overall survival and progression-free survival in this selected population of patients who had achieved response or stable disease already with prior induction chemotherapy. And we looked at presented data specifically in patients with low tumor burden, similar to what the CheckMate 901 trial did. And we saw that, of course, patients with low tumor burden, lymph node only disease, of course, they do better. They have better oncological outcomes compared, with patients with visceral and/or bone metastases. Dr. Belmont presented a poster with a post-hoc analysis of efficacy and safety in this subset of patients with low tumor burden. And those patients had, again, non-visceral mets at start of chemotherapy, or lymph node only disease. And what we showed was with a median follow-up that was at least 38 months, so at least more than 3 years. In all subgroup of patients, overall survival was prolonged with avelumab switch maintenance plus best supportive care versus best supportive care alone. Interestingly, if you look at the median overall survival in patients with non-visceral metastases, was prolonged, was almost doubled in patients with avelumab maintenance and also in lymph node only disease, either in the whole subset of lymph node only disease or in patients with pelvic and peritoneal nodal disease. In all those subsets, avelumab as switch maintenance prolonged overall survival compared to best supportive care alone in this subset of patients. Again, reinforcing the point that lymph node only disease is a favorable prognostic factor across therapies in this disease. And the safety was as expected. There was no new safety signal in that analysis, and the safety data were consistent with what we saw with the general population in that trial. So the other data point from the JAVELIN Bladder 100 trial, we look at histology subtypes. We know that that trial enrolled patients with predominant urothelial carcinoma, either pure or patients who had predominant urothelial with some degree of histology subtype, what we used to call variant histology. And we did a subset analysis. We looked at a number of patients, 44 patients with avelumab arm and 57 patients with best supportive care alone, and we look at those small subsets who had urothelial predominant but histology subtype as a minor component. And what we saw that, again, toxicity was as expected. There was no new safety signal. But in terms of the efficacy data, we saw that, as expected, there was overall survival benefit in patients with urothelial carcinoma mixed with histology subtype. In that subset, there was survival benefit with avelumab. The median OS was 19.3 versus 14.1 months, and the 3-year overall survival rate in this subset of patients was 37 versus 31 months. Again, these are small numbers, 44 and 57 patients, so it's hard to have a powered comparison here. It's definitely underpowered, and even the median PFS was double, 4.2 versus 2 months, favoring avelumab in this small subset of patients with urothelial carcinoma mixed with histology subtypes. And of course, the hazard ratio for overall survival was 0.74. Hazard ratio for PFS was 0.52. Again, in this underpowered analysis with small numbers, the conclusion is that the switch maintenance avelumab seems to favor patients who have urothelial carcinoma mixed with a minority component of histology variant. So Overall, the results were, as I would say, in the right direction in terms of the general overall population. Overall, we saw that we have great progress in the field of urothelial carcinoma, especially in the frontline setting. We had the JAVELIN Bladder 100 trial in 2020 and subsequent updates. And we saw great data in October 2023 at ESMO with CheckMate 901, Gemcitabine, and of course the EV302 with EV-Pembro. And we continue to see data from all these three trials, transforming the field and providing more options to our patients. Many questions, of course, are being generated. What do you do post-Pembro EV, for example, or post-Gemcitabine in that case, or even post the Javelin paradigm? And I think these are questions we need to answer prospectively in clinical trials. We need to keep evaluating options for our patients, novel mechanisms of actions, biomarkers. And of course, we're waiting to see the granular data from the TROPiCS-04 phase 3 trial. We saw the press release just on May 30th, but we need to look at the actual data from the TROPiCS-04 trial comparing sacituzumab to taxane or vinflunine, and this will come in the near future.